Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, the producer of Public Health on Call. Thank you for joining us for Vaccine Week on the podcast. Today, in a special two-part episode, we look at considerations of ethics and equity in vaccinating a nation. In part one, Stephanie Desmond talks to Johns Hopkins ethicist Dr. Ruth Fadin about the ethics of COVID-19 vaccine distribution and choosing who is and who isn't eligible to be vaccinated in the near term. They also talk about what happens when someone jumps the line to get what is, for now, a scarce commodity. In part two, Dr. Josh Sharfstein speaks with Dr. Chidinma Ibe, an assistant professor of medicine and the associate director for stakeholder engagement of the Center for Health Equity at Johns Hopkins. They discuss equity in vaccine distribution, or, put another way, why we have to do more than just count the number of vaccinations. Let's listen.
Ruth Fadin, thanks so much for joining me.
My pleasure, Stephanie.
So, Ruth, you are an ethicist, and we're talking a lot these days about the COVID vaccines that are out. And I think a big question in all of this is who should be vaccinated and how have those decisions been made?
So let's take them one at a time. The question of who should be vaccinated is actually really a question of who should be vaccinated right now. We're in a context where, despite the concerns, and they are very substantial, about how poorly positioned the Trump administration left the Biden administration with respect to vaccine rollout, and therefore the rest of us as well, as part of the country, it is still reasonable to think that we will be able to offer vaccine to everybody in the U.S. who wants vaccine in some foreseeable future, right? So whether the horizon is by the end of the summer or through the calendar year, or if we're lucky early in summer, we don't know yet. But we're still not at a place, despite the bad news of the fast yesterday and today, of thinking that we need to absolutely ration, right? So the question right now is really who should go at this moment, given the current state of the pandemic, the state of the epidemiology in effect, and what is our biggest concern or worry. So that's where we are right now. In terms of the planning, Stephanie, there were any number of groups that began thinking about how we should prioritize vaccines according to a sort of statement or framework of ethical values for the US, globally, and within many other countries in the world. And without going into the details, there was pretty much consensus across all of these efforts that the first recipients of vaccine, no matter what was going on with the epidemiology at the time that vaccines become available, should be high-risk health workers and people who are living in long-term care facilities. I could go through the ethics arguments why, but I think the listeners can pretty much figure out why. It's pretty self-evident why those two groups were pulled out for top priority, and also why it was justified to do so. So while right now in the States, we haven't yet vaccinated or offered vaccine to everybody in those two categories, we are now moved on to the next conversation, which is, okay, given that we've made a dent, and in some cases a very significant dent, in both of those two top priority groups, what should we be doing right now? In general, what we try to do from an ethics point of view, and also from a public health point of view, when we're trying to figure out this allocation problem, is ask ourselves, what are the underlying values? What are the objectives we want to achieve, right? And how should they mix with the epidemiology as we find it? So I'm going to stop and in case you want to ask me another question, or I can drill down a little bit more and explain what I mean by that.
Well, I think, the question is, right, so who comes next in terms of, I think that a lot of folks have said that the elderly should receive it because they're more likely to die if they get sick. Other groups have also prioritized essential workers. And I guess those decisions depend on sort of what kind of vaccination plan you're envisioning.
That tension is a great way of thinking about what are the ethics values that lie behind those tensions, those two groups. One of the major values or objectives that vaccination programs are intended to help us secure in the context of a pandemic is reducing the burden of severe disease and death. That's one of the reasons why we mount vaccination programs, to protect us from severe disease and death. We also simultaneously want to make sure that the vaccination programs we mount are equitable. And in particular, now equity takes on a very special meaning. This pandemic, as everybody knows, has laid bare the profound effect that background structural injustices experienced by disadvantaged communities of color and low-income people have manifested themselves. So we know that the burdens have not fallen equally on all of us of this pandemic. And the proportionate death rates, caseload, economic collapse, much higher in our communities that before the pandemic were already disadvantaged. So we're trying to hold both kind of values and objectives in mind. How can we use vaccine to reduce the burden of disease and death? And how can we do that in a way that at very least doesn't make these unjust differential burdens even worse, right? And ideally, even use vaccine to specifically narrow those disparities. So that's what we're struggling with right now. At this moment, when we've hit the 400,000 plus deaths as a nation, and what was it today, 4,000? I mean, it's a staggering number that we're seeing. The imperative to use vaccine to reduce severe disease and death, and also the crush on so many health systems around the world, hospital systems in particular, is extremely intense. But it would be a mistake to pursue a strategy that focuses on older people, which I believe is the right strategy, without that strategy being an equity-sensitive one. We have to think about how it's implemented.
Well, that's an interesting question because I signed up my over 75 mother-in-law for a vaccine. And when I did that, they asked me to put in her insurance card. So first I thought, well, I'm doing this for her because I have access to a computer and I know what I'm doing with the computer. Yeah. And then she is much more eligible because she has insurance. So right there, those are sort of two hurdles I felt as though I helped her to overcome, but not everybody has that.
So you're right on, Stephanie. There are really significant equity implementation issues. So it's not just sort of the equity issues behind the big decisions about which group goes first. It's within a group, right? How do we make sure, as much as we can, that access will be equitable? So there should be no barrier to pay with the over 65s. By and large, most people have Medicare or are eligible for Medicare, but even otherwise, there's supposed to be no obstacle, right? So this is more a bookkeeping thing for the city or the state to recoup than it is anything else. On the other hand, the barrier, or at least that's how it should work. I don't want to say that is how it works, but that is how it should work, right? So asking for insurance information may be off-putting, and that should be something to think about. But it's intended to allow for recouping, right? So to be able to figure out who gets to be charged for what. On the other hand, how to make the digital systems work, that's a big challenge, right? And it's a big challenge for many older people. It's a big challenge for people who are not older, who don't live online or who live online in a language other than English. So there are real equity issues there. And I do live in the District of Columbia, have commuted all these decades to Hopkins. And in the district, there is a phone number you can call if you can't manage to sign up online. All kinds of messages come out saying, please use the online system, please, please, please. And either way, it's frustrating. People wait forever. They have to keep refreshing and refreshing and refreshing, or redialing or redialing or redialing. But at minimum, there has to be an alternative to a digital sign-up system. There has to be a phone number where somebody can talk to a real human being, and preferably to a real human being in different languages. So that's one piece. Another piece from an equity point of view is thinking about where you set the cutoff, the age cutoff, because while it's true that most deaths occur from COVID over age 80 and then over age 75, those are mostly deaths of white people. Because as a community, white people live longer for all the same unjust reasons that there's more COVID in communities of color and in communities of poverty. There is also a shortened life expectancy. So we have to think about what the age cutoff should be from an equity point of view. And we also have to think about how to address where physically the vaccine is available. We have to make it easy for people to not only get an appointment, but to get there, to not have to queue for very long periods of time, to not have to take 2 buses or even a single bus. This is where mobile vans are going to be very important. And layered on top of all of that, we need what people have been talking about for what seems now to be forever, ways to meet people where they are with respect to their understandable, justified distrust of government public health programs, which is a real thing. And it's a real thing that needs to be respected. It has to be engaged with. And just to think that we're going to open vaccine programs and expect that everybody's going to come running to the doors in equal numbers from different communities across the country is incredibly naive.
A lot of work has been done among ethicists, among other experts on creating this priority system. And yet it feels as though it is broken down already.
To this. I think, yes, the answer is yes. And yes, it has broken down a lot in lots of different places. As I mentioned earlier, when people were developing these prioritization roadmaps, and I've been involved in a couple of these processes, it was in prospect, right? We didn't know exactly the state of the epidemic at the time that vaccine would be available. We didn't know the specific characteristics of the vaccines. How effective would they be? Would they be effective for people across the age span, for example? We didn't know about the supply. We didn't know how much vaccine would be available. We had guesses, we had estimates, we had projections, we had modeling, right, for all of these things, but we didn't really know now. Also, I think, so you could say that, let me just interrupt myself, you could say then that there was some sort of very reasonable, defensible plans put forward. That said, at least for some of the projected prioritization schemas, there was a level of detail and sub-prioritization and sub-prioritization that certainly in retrospect, but perhaps even at the time, should have been recognized to be way too complex, right? For a context in which we were going to have to mount massive vaccination rollout programs all over the country, right? Under very different circumstances with considerable under-resourcing of the effort, which is what we're facing right now. Hopefully that will shift. And an enormous urgency to get vaccine into people, right? So it's perfectly, it's frustrating, but it's perfectly understandable. And also, I think, hopefully necessary as we go forward for vaccination programs to be allowed to be flexible and nimble, right? And responsive to what we're facing. And a challenge we've got is to work with all of us in the public to recognize that it's going to happen. We're going to have to course correct a couple of times, maybe multiple times over the course of this pandemic, based on new science and based on new obstacles and based on new gifts. Maybe all of a sudden the pipeline starts opening up and we're in great shape. So flexibility, I think, and patience and a little empathy will go a long way right now.
It does feel, though, and I have to wrap this up, but it does feel as though there's also some frustration that, people are jumping the line. I see plenty of people in my young middle age who are getting vaccines this way or the other. And it's not because they're teachers and it's not because they're firefighters.
Let me say several things maybe about that from a sort of an ethics point of view. Queue jumping is not a good thing, right? So this takes years of study of moral philosophy to make this statement, right? This is something anybody's grandmother would tell you. You don't break into line. It is not a good thing. It's not fair to cut in line, right? If you find yourself eligible, even if you, for whatever reason, a higher authority, the state, your employer, tells you you are now eligible for a vaccine and you don't believe you should be, right? That's a different situation. So that's not really queue jumping. That you really think that the people who are setting the policy have taken a wrong turn here. And then you have a choice. I don't think it's ethically problematic if you say, well, I don't know why my employer just said I'm eligible. I'm not in any elevated risk. I'm working from home. You've been tapped. If it doesn't go to you, it's going to go to somebody else who's similarly situated in your employer context. That's just the way it is. On the other hand, if you want to say, I just don't feel good about this, I just don't think I should, also obviously an ethically appropriate response. But I want to distinguish between, true queue jumping. I'm going to try to game the system. I'm going to try to use connections or privilege or just extra knowledge that I've got to get someplace where other people who are otherwise just like me couldn't get. That's condemnatory. In contrast to a situation in which I may think it's kind of nuts or ethically not defensible that I'm eligible, but they just tap me and I'm eligible, so I'm going to go. Versus the last category, which some people are pursuing, which is we have this problem of vaccine at the end of the day. The vaccine has to be used within a fixed period of hours once the vial has been broken. So there have been different strategies that some vaccination sites have been, not like in your arm sites, but places have been employing, for example, CVS's or Walgreens that have been saying, we stop vaccinating at 8 p.m. You can queue up whenever you want to. If there are extra doses at the end of the day because people didn't show up or whatever, rather than throw away the vaccine, we're going to take you in order. That to me is not queue jumping. Truly, you might be taking advantage of the fact that you can line up starting at 4 in the afternoon and somebody else has to be at a workplace or working from home at that time. That is unfair, but it's not queue jumping in the same way. It is helping to get rid of vaccine to put to use, I should say, vaccine that would otherwise be wasted. And you'll probably wait in line and not get vaccinated because there's usually not that many doses at the end of the day.
Well, that was a fascinating conversation. And I think I could talk to you about this all day, but unfortunately, we'll have to end there. So Ruth Fadon, thank you so much for joining me.
Well, my pleasure, Stephanie. And hopefully someday we'll talk about happier things and happier times.
Indeed.
Right. Take care. Right. Bye-bye.
In part 2 of this podcast, Dr. Josh Sharfstein talks with Dr. Chidinma Ibe about equity and vaccine distribution. Let's listen.
Thank you so much, Dr. Ibe, for joining me to talk about equity and vaccine distribution. One way to think about equity is that it's a lot more than just counting the total number of people who've been vaccinated. Would you maybe start there?
Sure. And thanks so much for having me, Dr. Sharfstein. I completely agree that when we think about equity, it's not just the total number, it's really which populations have been most adversely affected by the pandemic and which populations have kind of borne a disproportionate burden of mortality and even transmission.
And it's not just who's had that problem in the past, but who's facing that increased risk right now.
Right, exactly. What we're seeing with this pandemic is that it's amplifying existing disparities and then even kind of reinforcing and creating new ones.
So the goal for equitable vaccine distribution is to make sure that people at high risk, people who live in communities at high risk, have great access to the vaccine. And it's not just people who are at low risk who are getting vaccinated.
Right. I think when you center equity in vaccine distribution considerations, what you said is really at the heart of it.
So how are we doing?
In my frank opinion, I don't think we're doing very well. I think one of the things that plagues us is we had an outgoing administration that did not really do the best job in coordinating the vaccine distribution. Now we have an incoming administration with Biden and Harris and the people that they've brought into their team who have really done a nice job of centering equity into the conversation at large, but they're burdened by what precedes them.
Yeah, it's a complicated environment right
Yes.
now.
Mm-hmm.
I mean, one thing that I've noticed is so many more people are eligible for the vaccine under the guidelines than we have doses of the vaccine.
Yes.
And so when you throw open the doors for vaccination, what tends to happen?
Well, when you throw open the doors, in the absence of a coordinated response, everyone is now trying to get vaccinated since they shifted the eligibility criteria to be everyone 65 and above, in addition to frontline healthcare workers or frontline providers. And it's kind of created a cacophony of dysfunction. I'm sorry to put it that way, but I can't think of any other way to describe it at present.
It's almost in some areas like people trying to get tickets to a concert.
Right.
And it seems that people have different access to a vaccine when this throw open the doors approach is taken. Do you think that's fair?
Yes, I think that's a fair assessment of what we're seeing. You know, it's a challenge because on the one hand, there's different access to the vaccine itself. Then we have issues around what people typically have been framing as vaccine hesitancy, which I take issue with that term in some ways because the hesitancy is not just emerging from what has happened in the past. It's also ongoing issues of discrimination that people are encountering in the healthcare system at present.
So let's tease those two issues out. So just in terms of people's ability to connect to a vaccine distribution system, I mean, if there's online scheduling, you have to get online.
Right, exactly. And there are people who are not able to get online. There was this really interesting report that was done on the digital divide here in Baltimore. And I think that it may have been written in the context of schooling in this pandemic environment. But what it really hits at is that there are people who can't even access the information that will allow them to get scheduled to get a vaccine because they don't have access to the resources that let them do that sort of thing.
And then there's also time, because if there are 12 different places that may have vaccine, some people can spend an awful lot of time, checking because they really want vaccine, and other people can't spend that kind of time.
Yeah, I agree. And I appreciate you bringing time up as a factor, because I think sometimes when we consider issues of equity, we don't even think about something as simple as time also being, structured by inequities at large.
And then there's the where. If vaccine is more accessible to certain communities geographically, that creates a pressure that might undermine equity.
Right. That's absolutely the case. I've seen stories where I saw a story that someone posted where they were offered a vaccine that was 7 hours away from them. So that even gets to your point earlier about time. It's not just the time it takes to identify where to get vaccinated. It's if it's so far away from you that it's virtually inaccessible, do you even really have the opportunity to get the first and hopefully second dose of the vaccine when the time taken to get there is just so long?
So I want to go to the second point you were making, which is around how people are thinking about the vaccine itself. So if there's this shortage situation and some people have no doubts or questions, they're going to jump right in and try to get the vaccine. Other people who may be wondering, have certain questions about what could happen to them, or they just don't understand very much about the vaccine right now, they may be hanging back a little bit and as a result lose out on access. And I think what you're saying is that we don't want to blame people for feeling that way, or just say like, well, they didn't want the vaccine, so what do you expect? There's something else going on here.
Yeah, you're right in that is what I'm saying, that we really need to understand and attend to some of these underlying contextual factors that are shaping people's desires to be vaccinated or their reluctance to be vaccinated. And it almost seems to me that, there are two different things happening where there's a targeted approach that needs to happen, that needs to account for these two different realities. Outreach that is community centered and really makes sure that it is focusing on some of these concerns, these valid concerns that people have, but then also targeted vaccine distribution such that the people who really need it are getting it. And when we're talking about who really needs it, I'm trying to be clear that I mean the communities that have already been disproportionately affected, that they're getting what they need, and that we're trying to think about how to do these two things at the same time, but also, again, with this overarching focus on equity and valuing people's perspectives and experiences.
So, with the chaotic rollout of the vaccine so far, the early indications are that there's not that much equity in the distribution, that actually some divides related to the vaccine may actually be growing wider, some divides related to the pandemic. And there are health officials, there are states that are trying to overcome that. But those attempts have run into challenges.
Yes, they have. So what comes to mind is the recent New York Times article that came out that was highlighting what was happening in a predominantly Black county outside of Dallas, where their public health officials were trying to create a more targeted approach to supporting vaccine distribution and uptake among the Black and Latino members of the community. And unfortunately, they encountered resistance from the state officials. And I think part of what is happening is people are framing this in terms of preferential treatment, and it's not using the language of equity when we think about who has been most affected and why we need to actually shore up resources for those who have been the most disadvantaged during this period.
Right. So just a pure first come, first serve may seem like the most fair to people. On the other hand, it might not be fair when you take into account the barriers people have to be able to access vaccine under that kind of system.
Yeah. With what you just said, it reminds me of this picture I've seen that describes the difference between fairness and equity, where, everyone is trying to look over the same fence. And there's this idea that, we're all able to look over the same fence. There's no problem. But the equitable approach is you put steps up so that people can peer over the fence and have access to the same view as others who might not need those steps. So it's really thinking about, using that picture as an analogy of this whole vaccine distribution phenomenon. What steps do we need to implement that will allow people to get the vaccine, the people who need it?
Right. To use your analogy, rather than just blaming people for not being tall enough to see over the fence on their own.
Exactly.
So let's think about strategies that might overcome this, that may be more politically acceptable in different areas. I'm noticing that some health officials are putting together teams to go specifically to communities that have been hit hard by the pandemic and deliver vaccines specifically to them. Do you see value in that kind of mobile strategy?
Yeah, I do. I think that's an awesome strategy, actually. I think a lot of times when it comes to things related to healthcare, we as public health and, medical professionals tend to think that people will come to us. And the reality is that people are living their real lives in their homes, in their communities, in their institutions of worship. And we need to be figuring out how to meet people where they are rather than expecting us to come to where we are, given that there's so many barriers to them accessing our institutions or organizations or businesses or whatever to begin with. So I think a really targeted approach is necessary and is really the best way to go about it. And that these approaches really need to also be coupled with strong community engagement so that we even know where people are going, where they want to go, and that sort of thing.
Now, this kind of strategy is challenging for some of those reasons. It takes time. You may want to go out, see who's interested in getting vaccinated, but talk to people who still have questions, plan, a mobile clinic, bring people out. While we have millions of vaccines to distribute, it may not be possible to do everything through a mechanism like that. But you could get started.
Yes, you could get started. I mean, you're right. It's challenging to do that, to adopt that sort of approach, because it does take time. And really, we're at a point where time is of the essence, but we have to do something. And even if we can't do it in the most perfect way in terms of, this full throttle community engaged approach, we can adopt some aspects of it that will maximize our capacity to vaccinate as many people as possible in a way that, again, just ensures that it's done in an equitable manner.
So it's partly having places for vaccination where people who are ready for the vaccine can come, and also bringing the vaccine out to communities that are particularly in need and really working with them to encourage vaccination.
Right.
What do you think is going to be the most important consideration or the kind of the critical factors in whether that switch can happen as we emerge from this vaccine distribution chaos?
That's a great question. And honestly, I've been asking myself that same thing. I mean, this really seems to be something that is truly multi-level in every sense of the word, because you need support from the highest levels of leadership to ensure that certain policies and practices that are proposed will actually happen. Then you also need support from people who have some measure of influence within a community and can help persuade those who have concerns. And like we're saying, they're valid concerns, but if these concerns are kind of preventing them from getting what could actually be of help to them, we need people that are going to be willing to help persuade people to become vaccinated. I know this may not be the best researchy, way of putting it, but this is almost kind of like an all hands on deck type of thing where, again, everyone at every level is going to have to figure out how to reconcile themselves to the reality that adopting an equity-based framework in vaccine distribution is the way forward and ensuring that people are getting it.
In other words, an equity framework needs that same kind of supercharged investment as setting up a mass vaccine site.
Exactly. I mean, for the vaccine itself, there was Operation Warp Speed. We almost need like an Operation Warp Speed when we think about equity, and it could entail even just instructing people on principles of equity. But I know that education is not sufficient, and we live in a time where, not everyone has come to agree about these very principles.
Mobilizing a community workforce, and the Biden-Harris administration's thinking of 100,000 people to join this effort across public health. The messaging, where clinics are located, all these different things requires, as much investment as just taking the football stadiums or the basketball stadiums and saying, people who want to can sign up online for a dose.
Yeah, I agree. One of the things I've been really encouraged about is actually what's happening here in Baltimore City. And from that standpoint that, you have a mayor who is very engaged and really thinking about this issue. You have this cadre of community health workers that have been trained as contact tracers that could be redeployed to help with vaccine distribution. There's a lot of political will within the city that seems to be favoring what we're talking about. What's going to be interesting to see is how the residents of the city themselves, respond to these efforts and how that will shake out.
Well, maybe we'll have you back on the podcast to discuss what's happening. I do know there are a lot of people thinking about exactly these questions in Baltimore, led by the health commissioner, Dr. Terraza. Thank you so much, Dr. Ebay, for joining me to talk about this, and look forward to talking to you again.
Thank you, Dr. Sharfstein. It was really my pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.